everybody, and welcome to Late Night in Canada. I'm your host, Clare Blackwood. I'd like to begin tonight's show by addressing the elephant in the room. Right now, I bet you're probably thinking, things look a little different around here this week. And you'd be right. I moved on from my old view of Toronto because, funny story, a friend pointed out to me this week that the old background image had the Trump Hotel right next to my head the entire time. That's horrifying. The only time I'd ever want to be that close to Donald Trump is if I'm staring at him through the bars of his public shame cage, where we can pelt him with fruit he'll never eat and read him notes from parents who love their children to remind him of what he'll never have. But enough about him. This is a Canadian show, goddammit, and already I can feel myself sinking deeper into the dark, bottomless hole from which I barely clawed my way out after the 2020 presidential election. So let's get to the news with This Week in the North. On Monday, it was announced that officials are looking into making Canada's Wonderland a COVID-19 vaccination drive-thru site. One vaccine will cost $50, or you can get a season's pass of doses for only $73.99, and it comes with a free funnel cake. On Tuesday, Ontario Premier Doug Ford was interviewed about Ontario's reopening on CTV's Your Morning, and had this to say after once again being asked why he was not reinstating paid sick leave for workers.
Well, right from the get-go, Anne-Marie, we aren't going to duplicate and waste taxpayers' money.
You know what? I get why he says that now. When it comes to waste of taxpayers' money, it really takes one to know one. Canada's Liberal Party introduced a buyback program for illegal firearms on Tuesday, after banning assault-style weapons last year. The statement said that anyone who does not wish to give their blacklisted weapons back will have to agree to never use them, give them to anyone else, or obtain any more of them. Fans of assault weapons are calling the buyback program the angriest we've felt since the time we were told that Canada didn't have a Second Amendment. The big story on Wednesday was a heated debate between the leader of the official opposition, Andrea Horwath, and Doug Ford during sitting period at Queen's Park. Horwath criticized the Premier's handling of information and negligence in long-term care homes. How dare she scrutinize his policies and hold him to account, when her actual job as opposition leader is to scrutinize his policies and hold him to account. Moving on. Now, we can all assume that Ford might not have the best answers to her accusations, but I'm sure he at least handled himself like a responsible adult and responded in a way that was respectful of Horwath's position.
You know, it's like listening to nails on a chalkboard, listening to you.
Oh, no! You do not insult the woman who wants to give me free dental care. That is where I draw the line. Andrea, I know you were too dignified to burn him back in the childish way that he deserves, and I love that for you. But don't worry, I'm dedicating my first ever segment within a segment to you. May I present the burn list? Alright, Dougie, you want to talk shit? You want to lower yourself to dumb insults instead of mature political debate? Well, let's go, bud. We're going to do a list of all the things your opponents wish they could say to you, but don't, because people would dox them on Reddit. But I don't care, because no one knows who I am, so here's your burn list. Number 1. Your hair looks like it's from a rejected Wallace and Gromit cartoon. Number 2. Seriously, how wide are the teeth on your comb? Number 3. You stand like a downhill skier who has never had hands before. Number 4. You always look like you've been Freaky Friday'd with a washed-up, middle-aged boy band member forced to wear a suit for the first time. Number 5. If Horwath's voice is like nails on a chalkboard, your voice is like if the chalk became sentient and was disappointed in how its life turned out. Number 6. Your face is as generic as your cherry cheesecake recipe, but at least the recipe looked tasty. Number 7. Whenever you call me your friend in your press conferences, I throw up a little bit in my mouth. And number 8. Enough said. And that, my friends, was the burn list. On Thursday, it was announced that Ford, Jesus, this guy, met with a 7-Eleven executive at the company's Texas headquarters to discuss the possibility of on-site sale and consumption of alcohol in its convenience stores around Ontario. That would explain the new 7-Eleven ads I've seen popping up. The meeting was omitted from the Premier's official news release about his Texas trip, because just like passing out from too many Labatt 50s beside the big gulp machine, some things you just can't admit, even to yourself. On Friday, the federal government announced that it will be extending the Canada Recovery Benefit eligibility period by an extra 3 months because many jobless people are facing the prospect of being cut off by the end of March. That does seem a little quick. I mean, it's not like March starts in a week or anything, making it a whole year since the entire world shut down and I was locked in my apartment alone and... And finally, a new poll came out that stated that British Columbians are officially the worst province in Canada at following COVID-19 rules all the time. Ha! Suck it, BC! You might have beautiful weather, stunning mountains, lush forests, organic food, and this weird concept called chill, but we Ontarians can lie better on polls. And that was This Week in the North. As Canada's internationally acquired vaccines trickle in at an alarmingly slow rate, many people are finding themselves asking, what the hell, Trudeau? Why aren't we making our own vaccines? Why do we have to rely on places like the US and Europe? Are they better than us? Are they cooler than us? I mean, sure, Europe thinks it's cooler than us because it has things like free university and style, but is it true? Well, much like my fictional but very sexy relationship with Tom Hiddleston, oh yeah, this is going to be a long-running joke that's not going away anytime soon, so hop aboard the Hiddle train and strap yourselves in. The answer is complicated, and there isn't one person or one government to blame. Instead, we have to spread the blame out over decades of budget cuts and short-sighted federal decisions, like the world's shittiest peanut butter sandwich. I'm going to be looking at why we didn't make our own vaccines when the pandemic first hit, and what we're doing about it now in this week's The Focus. One of the biggest problems we're facing with vaccines right now is that because we're not making them ourselves, we have to wait until the popular kids give them to us. Canada is definitely feeling like the kid in the monkey bars who no one asked to play with them because he just moved here from a small town, he's really quiet, and everyone has too many friends to hang out with already. It's not like Canada can't manufacture vaccines in general. A major Toronto manufacturer, Sanofi Pasteur, is a leader in vaccine production, but the challenge is that it's already committed to making a lot of other vaccines, including pediatric ones, that it can't just put off to the side. We can't ask facilities to just switch over or immediately construct new buildings. There are laws, rules, and strict health regulations to adhere to. Also, anyone who lives in Toronto knows that it takes the city like a minimum of 10 years to dig the first hole in the ground, and if it involves transit, that number is multiplied by, infinity. I'm looking at you, Eglinton LRT, you flaming pile of garbage. I could build a subway line faster than you, and I don't even know how electricity works. And to all those saying, we can make the flu vaccine, why can't we just switch it over to work for COVID? I'll let medical historian Christopher Ruddy take the wheel.
It's not like a flu vaccine for a pandemic flu is based on an existing technology we've had for many, many years. It's well experienced with it. It's well regulated and licensed. There may be variations in it when we have a pandemic, but essentially the same type of vaccine. But with coronavirus, we're dealing with multiple types of vaccines from various producers around the world, and trying to do this in the context of a pandemic.
Oh man, that guy just looks like a historian, you know? I kept expecting him to open one of those boxes behind him and pull out the Holy Grail from Indiana Jones and the Last Crusade. But I digress. Basically, asking our existing labs to just suddenly make coronavirus vaccines is like turning to Apple and asking them to make us 70 million Mars rovers by the end of the year. Holy shit, that would be cool though. So, why couldn't we make COVID vaccines ourselves when the pandemic began? Let me take you back in time, friends. Oh god, not that long ago, let's cut that music. Let me take you back in time to about 50 years ago, when bell-bottoms were all the rage, disco wasn't shameful, and Canada was considered a world leader in domestic vaccine production. Conant Laboratories in Toronto was known for creating insulin for diabetes and vaccines for illnesses like polio, and a lab in Montreal created injections to ward against tuberculosis. But a lack of profitable business models caused them to be sold off during Brian Mulroney's Conservative government's privatization program in the 80s. Canada also lost facilities run by AstraZeneca, Johnson & Johnson, and Sanofi under several Conservative governments. Alan Bernstein, the president of CFAR, a Canadian-based global research organization, explained that in addition to the depletion of Canada's biopharmaceutical industry over the last few decades, we've let issues like vaccine production slip because, well, it just wasn't a necessity, saying, the problem has been that governments are driven by short-term needs, and in the absence of COVID-19, there was no obvious immediate need to have a national vaccine facility. We've let it slide. It's like PPE. It's been just as easy to buy vaccines offshore. Oh boy, if the egg on our faces were any fresher, Doug Ford would want it on a Tim Hortons breakfast sandwich. Call back! In November, Trudeau stated in the House of Commons that domestic manufacturers had been considered when Canada was originally making deals for vaccines.
We know how important it is to deliver for them quickly, and in signing the contracts, yes, we looked at different ways of ensuring domestic production as much as we were able to, but that unfortunately is not something we can move forward on.
Oh, he mad. You can tell because his beard grows visibly grayer whenever someone from the Conservative Party boos him from across the aisle. Basically, by the time the Vaccine Task Force had to look at where to get our vaccine contracts from, it was too late to begin making the first round of the COVID vaccines here. Buildings take time, regulations are important, and we didn't even really know exactly what type of vaccine we need to make or what resources we need to make it. So they looked at the cold hard facts. Where can we get vaccines from reliably for this pandemic specifically, not just future ones? So, we didn't have the facilities or equipment last spring when Canada was forced to make crucial decisions about getting it as quickly as possible so we can all go back to our lives of talking too closely and drunkenly making out with strangers in dive bars. But what about now? Providence Therapeutics, a Calgary-based manufacturer, began human clinical trials of their mRNA vaccine in January. Although they did state that they had the vaccine designed as early as last March, but didn't get the funding they needed to manufacture the numbers required. Again, the government had to look at the numbers. We'd have been starting from scratch here, as opposed to piggybacking onto larger companies like Pfizer and Moderna, who already had the necessary capabilities, even if it means that we were going to have to wait to be prioritized. Providence is hoping to have the next vaccine ready to go for January 2022. Manitoba has purchased 2 million doses in an advance contract with them, and Alberta is considering doing the same. Saskatoon's Vaccine and Infectious Disease Organization, or VIDO, had early promising research but also lacked manufacturing capabilities. However, with millions of dollars of new federal funding, VIDO is building what it needs to create in-house vaccines in future. It's currently recruiting volunteers for a phase 1 clinical trial in Halifax right now. We did make a contract with a Canadian-made option from a company called Medicago in Quebec. It received $173 million in federal funding, and its vaccine candidate is currently in phase 3 of clinical trials, with an estimated 80 million doses to be made by the end of 2021. And it's plant-based. Were the other vaccines meat-based? You know what? I don't care. Just put it in my veins. Basically, we missed the boat on this pandemic for reasons that were unfortunately often out of our control, at least in terms of being domestically prepared. According to Michael Gardam, the Chief Operating Officer of Health PEI, if we're in phase 1 or phase 2 of clinical trials, by the time this Canadian vaccine may be approved, the pandemic may largely be over. But the concept is a good one. Ouch! That quote is the equivalent of those participation medals they used to give us in track and field. Good job, Timmy! You crossed the finish line, and only after stopping to sit down and pick your nose for 10 minutes. At least you tried. Right now, our hope is to be first in line to combat the next plague that rolls into town. We'll also be able to provide COVID boosters and protect ourselves against other future COVID strains. So, who knows? Maybe by the next pandemic, and there will be a next pandemic, Canada will once again be a leader in vaccine production, bell-bottoms will be back in style, and disco music will be... Actually, let's not go there. This has been The Focus. My guests tonight are Rachel Bromberg and Asante Haughton of the Reach Out Response Network, a coalition of community stakeholders who are partnering with the City of Toronto to create a new mental health emergency services program, essentially replacing the police with trained health clinicians for mental health crises across the city. I sat down with them to talk about their organization, their goals, the stigma their project faces, and how you can find out more about them. Take a look.
Thank you so much for coming on the show, first off. Thank you. Appreciate it.
It's so nice to meet you. I think what you two are doing is incredible, and obviously it's so necessary. I mean, I say especially now with what is going on in the world and what happened last year, but it's always been necessary. We just haven't been doing it. So I would love for people to get a sense of who you are and what you're doing. So if you could give us a kind of overview about what the Reach Out Response Network is all about and how you two came to found it, that would be awesome.
Cool. I guess first we'll introduce ourselves. So my name is Asante Haughton, and as you probably have discerned by now, I'm one of the co-founders of the Reach Out Response Network. With Rachel, I have a lot of lived experience and professional experience in mental health, and for me, my main motivation to advocate is to not see folks go through the variety of different things that I've lived or seen in the field throughout my life. That those things have not been very nice. So trying to stop all that. So I'll pass it over to Rachel now.
Yeah, I'm Rachel. I'm the other co-founder of the Reach Out Response Network. I also have my own lived experience, and I've also been working in the mental health field for 7-ish years now. And I've worked a lot with crisis lines and suicide intervention services and at mental health agencies. And that's actually how Asante and I met. We were working together at Stella's Place, which is a youth mental health agency. And I guess I could say a little bit about how the Reach Out Response Network got started and what we're doing, if that would be helpful.
Yeah, that would be great. That's perfect.
Yeah, so when Asante and I were working together at Stella's Place, we had a lot of conversations about the current state of the mental health care system and what's working and what isn't. And one of the things that we talked a lot about was the way that police response to mental health crisis can act as a barrier for people seeking support. Like particularly for me, I'd worked at suicide intervention services, and I'd had a lot of experiences of people who were in crisis but didn't want to talk about how they were feeling or what they were thinking about because they were afraid that if they did, then police would get involved, and that was really scary for them. Maybe they'd had bad experiences like that before, or they'd heard these stories of bad things happening to other people, or it just felt like very stigmatizing and uncomfortable for people. So Asante and I talked a lot about this, and at a certain point we thought, well, hey, we could do something about this. This isn't just like a static problem that is inevitable, that exists everywhere. There are probably other cities that are doing a better job than Toronto is at responding to these kinds of crises. So we started to do some research. We started to learn about different programs across Canada and the US that have non-police responses to mental health crisis. And we learned about what the best practices are. But at that time, this is probably about 2 years ago now, at that time, there wasn't a lot of interest in Toronto in bringing a new service here. People thought, what we have is already working. Why change it? Changing it is going to be a lot of work. It's going to be hard. It's going to be expensive. Why do it, basically? Yeah. And that really changed last year after, obviously, George Floyd's death and the deaths of 5 Canadians in mental health crisis in a very short period of time in Canada during interactions with police. And that led a lot of cities, including Toronto, to realize that change was needed. So at that time, there was a motion that was put through City Council, passed unanimously, directing the city manager's office to put together a report on how a non-police mental health emergency service could be implemented in Toronto. And because Asante and I had already done all this research and all this work, we stepped in and we said, hey, city staff, we could help you with this. So we officially formed our organization, incorporated it as the Reach Out Response Network, got a large number of volunteers working with us, and signed a contract with the city we supported them in writing a report, making some recommendations about what the service could look like based on our research and also based on a whole bunch of town halls and community engagement work we did last summer. We did 20 town hall surveys, focus groups, and about 120-ish individual interviews and key stakeholder interviews. Wow. We put all that information together to make recommendations to the city based on all of that.
So we did a lot, yeah. We did a lot. That's like the short version. That's like the short version too, yeah. So
yeah.
So
I guess my next question to you is, how exactly do you want this program to work? Like best case scenario, um, how will it function with other first responders and like, you know, with those other organizations in Toronto?
I think best case scenario is very simple. People are not getting hurt during these sorts of interactions, and people are getting help during these interactions instead. And when I say help, I don't mean just immediate crisis intervention in the moment, but getting support to have some meaningful change happen in their lives so that they don't end up in crisis or distress. Again, one of the things that we really see in the industry, when I say industry, I mean in mental health, is that, folks end up reusing services often, especially those who experience the highest levels of distress, because we're actually not doing that much for them. When the response happens, again, it's about trying to get the person's, quote unquote, stabilized in the moment. And then after that, it's kind of, well, here's a card, call this doctor, and you're sort of on your own. Right? So we have to do far more than that to ensure that people are getting help and to ensure that people are getting the support that they need and moving toward a brighter future. And, Rachel, you probably have a lot more to say about this as well.
Yeah, I think in terms of what this service is going to look like in practice, what we envision is mental health workers, including peer workers, replacing police response to nonviolent mental health crisis, which, as we know, is the majority of mental health crisis. So what we imagine, 5 years from now is that, right now, police are the default to responding to everything, but particularly to responding to mental health crisis.
Which they shouldn't be.
Right. So we imagine that being inverted, where the default response to a mental health crisis 5 years from now is a mental health worker. And, we're seeing that. So City Council 2 weeks ago, in COVID times, dates are difficult. I think it was 2 weeks ago. City Council unanimously passed the motion supporting the creation of this new team. And what the new team is going to look like is, well, it's going to start off as a pilot that'll operate in 4 different parts of the city. There will be agencies in each of the catchment areas that will be operating the service. So there will be like a request for proposal process, and agencies can apply to operate the service. And the service will be accessible in a few different ways. So you can access it through calling 911, you can access it through calling 211, you can access it by calling the agency directly. But either way, these agencies are going to employ mental health workers, peer workers, others who have experience responding to these kinds of crises. And in these catchment areas, those folks are going to be the ones who respond to person in crisis calls or welfare checks or other mental health related situations that right now police are the first responders to. And what is being planned is these pilots are going to run for 3 years, and they're going to be evaluated regularly, and there'll be reports every year back to council. And by 2025, this program, assuming it works well, which we expect it will based on the international teams, it's going to be rolled out across the entire city. So by 2030, anyone who calls 911 in a mental health crisis or for someone else who's having a mental health crisis, the people who respond to that are going to be mental health workers. It's not going to be police anymore.
That's awesome. And so vital. And okay, so another thing that really struck me is I really like how you say that it's necessary for your team to be created by and for the people in the community. So obviously that means trained mental health clinicians, but how much does volunteering play a part in this? Like if somebody was interested in your organization and wanted to reach out to get involved, but didn't have professional mental health training, is there a way for people to do that?
So the teams that we're proposing are not going to be run by us. We are not operating the service. They're going to be operated by community agencies, and there will be like a process for people who want to work on the teams. It's going to be paid staff. But for folks who want to get involved with our organization, they can go to our website, reachouttoronto.ca, and learn about all the different opportunities that are available.
Yeah, and what I would add is definitely that we, in the telling of our story, I know that we kind of said, a lot about myself and Rachel. However, we did not do this alone, and it definitely did take mobilizing so many community members, thousands of people, to get this issue, essentially to be taken seriously. I mean, it sort of was because of the climate around George Floyd and everything else that was going on. But, when we approached the city at the beginning, they were kind of like, these young people, they have a bright idea, whatever. And that's, no disrespect to them. We didn't really have any established evidence as to why we would be credible. Right. So, we developed that also in large part by engaging with so many community members and being able to do that so effectively. So, yes, anyone listening out there, I mean, please do reach out to us. No pun intended, or maybe pun intended, I don't know. And, we'll see what we can do to support each other in making things happen.
Cool. I know that programs like this have been very successful in other countries around the world. Have you run into roadblocks creating this, or having to deal with false assumptions about it? Like people being like, oh, they're just going to replace the police and everything. Or I know you have a lot of data on your website about all of the stuff that you're saying about, people getting hurt because, what happens if there's guns? What happens if there's knives? Like, you don't actually have to deal with that. So, yeah, I just love to know about the kind of challenges that you've faced so far in creating this program.
I mean, we've definitely had to address some stigma and questions from it. I think people might assume that these things come from, certain kinds of people, but realistically, probably because of the way that we've not talked about mental health and mental illness in the past, it has allowed these sorts of assumptions to fester and grow. I mean, the biggest one probably being, what about the crazy person with a weapon, and what's going to happen there? And well, there are lots and lots and lots of statistics that show that the absolute rarity of anyone getting hurt when non-police teams are responding to these sorts of calls. Rachel has the stats, which I'm sure she'll share with you. But essentially, the incidence rate is less than 1% to the extent that you have to do 3 decimal points to get to what the percentage is. So I mean, that's the biggest one. Probably. And, of course, people also talk about, defunding the police and all of these things, right? And, for us, it's about, we're not having a strict defund the police conversation. For us, it's not, oh, we hate the police. It's for us, we love, proper healthcare is kind of what we're about.
Novel idea.
Right? So, it only makes sense for folks to, folks who have the ability and the experience to respond to these calls, mental health crisis, those people should be the ones responding. So anyways, Rachel, bring in the stats.
Our whole thing is that mental health crisis is a health crisis. It's not a crime. Police exist to respond to crime. Mental health workers exist to respond to mental health crisis. It's obvious. And, we've because this is a question that we get a lot of, we have done a lot of research in terms of what percentage of these calls actually are violent or dangerous, and what are the outcomes for the teams that do exist. So what we found is that 89% of 911 calls related to mental health crisis just have no risk of violence whatsoever. There's no weapons, there's no aggression, there's no threats. It's just not violent. So that's low-hanging fruit, 89% of calls right there. And then what we know is from the teams that have been operating in other cities, Cahoots is a team in Eugene, Oregon. They've been operating for 31 years. They are crisis workers who can be dispatched via 911. They're on police radios, but they're completely civilian team. They're made up of just mental health workers, peer workers, crisis workers, and they responded to 24,000 calls in 2019. So they take a large volume of calls. And, from their team and from many other teams that have been doing similar work for long periods of time, we asked all of these different teams, what is the rate of injury for your frontline staff members, like when they're going on these calls? And what we found is that there had never been a serious injury or death of any staff member ever on any of these teams. And again, like Cahoots has been operating 31 years. They take a large volume of calls. And in terms of like minor injuries, like even, like a team's car getting rear-ended on their way to a call or something like that, mostly not things to do with clients, but things like just occupational safety and health and that kind of thing. That those kinds of incidents happened 1 in every 21,700 calls. So like very, very, very small percentage. Like maybe for a team like Cahoots that takes 24,000 calls, maybe it happens once a year, maybe. So this misconception that people have about like these calls are dangerous and scary and violent and your social workers are going to get killed, it's just not borne out by the facts. And we've thought a lot about like why do people have this misconception? And in our experience, it's because people associate police so strongly with crime and violence and danger. So if they see police responding to a mental health crisis, they're like, oh, this must be because the person in crisis is dangerous and violent and scary. And so it just reinforces itself. And we really hope by getting police out of there when it's possible to get police out of there, and making sure that the right people, the mental health workers, are responding to these kinds of crises, that'll reduce that stigma and that false association that people have.
That is amazing. Great. Well, again, like Rachel said, you can learn more about the Reach Out Response Network at reachouttoronto.ca. Asante, Rachel, thank you so much for giving me your time today. Thank you for the effort and the energy that you're putting into this project. I wish you all the best.
Thank you so much for having us.
It was so nice to meet you.
This has been Late Night in Canada. Thank you so much for watching, and I'll see you next week. Unless my beloved Tom Hiddleston sees my incredible Photoshop skills and whisks me away to court to sue me for stalking. Good night!